would hand over to you. So, good evening, everyone. I take this opportunity to welcome our Director General Health Services, Dr. Atul Goyal. And I would also like to welcome our panelists for today. Dr. Aravind, the Head of Department Infectious Diseases, Government Medical College, Thiruvananthapuram. Dr. Sumit Rai, Professor and Head Department of Microbiology, All India Institute of Medical Sciences, Mangalagiri. And Dr. Ranganathan Iyer, he would be joining us shortly, Director Clinical Microbiology, Infections and Infection Control, Rainbow Children's Hospital Group, Hyderabad. So the emergence and rapid spread of antimicrobial resistance poses a grave threat to public health globally and particularly so in India. With its unique combination of a dense population, a significant disease burden, and diverse healthcare practices, we stand at a critical juncture in the global battle against AMR. The implications of this escalating crisis are far-reaching, threatening decades of medical progress, undermining healthcare delivery, and posing potential roadblocks to the realization of several sustainable development goals. AMR occurs naturally over time, usually through genetic changes. However, the misuse and overuse of antimicrobials is accelerating this process. The One Health approach for AMR containment has inadvertently led each sector to focus more on the risk factors in the other sectors, while knowing very well that each sector can take action for AMR containment only in their own sector and has a fair share of work to be done within their own sector. Accordingly, this year during the World AMR Awareness Week, with the theme Educate, Advocate, and Act Now, we have taken up the theme of antimicrobial stewardship in practice, optimizing prescription practices, which is a very important action for AMR containment in clinical practice. So I would like to ask the first question from RDGHS, Dr. Atul Goyal. Sir, AMR is an urgent threat to modern medicine. However, despite the knowledge that inappropriate use of antibiotics is the most important contributor of AMR, the syndromic management of infectious diseases continues rampantly, causing overuse of antibiotics. Sir, is overprescription of antibiotics a real issue in India? And how can a physician convince patients who come asking for antibiotics in OPDs, including the CGHS dispensaries? Sir, I request you to please respond to this question.
You're on mute, sir.
Sir is on mute. Yes. It's now. Can you hear me?
Yes, sir.
Yes. So I said the problem of AMR is grave. The issue is that yes, over prescription is also a problem. However, there are two things about over prescription. Over prescription does not take place in government sector and CGHS dispensaries. Over prescription to a very large extent occurs in the private sector, and the misuse also occurs in the private sector. Rampant use of reserve antibiotics in the ICU settings of private sector and mindless changes on an everyday basis creates a bit of a problem. Yes, the issue is that we will have to put some restrictions on the prescriptions of antibiotics by various categories of doctors. And unless we take this tough step, I don't think we are going to solve this problem of AMR easily. Kerala claims to have done a very good job with AMR, but then they have not been able to make inroads into the private sector, which controls nearly 65 to 70% of healthcare there. So the problem in India is 65% of the healthcare is taken care by private practice, by the private medicine people. However, there is absolutely no regulation of use of antibiotics out there. And let me tell you, if the doctors are themselves equipped with adequate amount of knowledge about use of antibiotics, it's not tough to convince patients. I agree there is a generation of patients who read Google, who take antibiotics by themselves, but then it's not a prescription problem. That's a problem with those patients. Those patients need to clearly understand that by taking antibiotics themselves, they are actually opening themselves to risk of infection with serious resistant pathogens as well as risk for death due to that infections. So I mince no words when I state this, that more than over prescription in the government sector, it's the over prescription in the private sector. And the last point I would like to add in my answer is that till these prescriptions are driven by commercial interests, which they are, there is no easy way out to prevent AMR. So I think that should be adequate answer to your query, Lata. Dr. Lata, can you hear me? I think there is a problem with Dr. Lata's audio.
Ma'am, you're on mute.
Huh?
Madam is on mute mode, ma'am. Lata ma'am, you are mute.
Unmute. Yeah, I think they had muted me, the hosts.
Lata,
So,
that's the
yes.
whole problem. That's the whole problem with Zoom, I'm telling you.
Yeah. Yes, sir. So thank you so
Could
much,
you
sir. Yeah.
could you hear my answer?
Yes, I could, sir. I could hear your
I
answer.
hope you could addressed all your queries.
Yes, sir. Absolutely, it did. And it also addressed that if we have patients who come to CGHS dispensaries and ask for, we need to educate our patients and tell them how serious an effect it can have.
No,
But
Lata,
private sector,
the problem is that today the CGHS patients are also going to the private sector, getting those prescriptions and coming to CGHS dispensaries and demanding antibiotics because the private sector has prescribed. They believe what is prescribed by the private sector is probably better. I think that needs to be looked into. It's not the CGHS doctor who's overprescribing antibiotic.
yes, sir. Thank you so much, sir. Thank you so much. And now I go to my next question, which is to Dr. Ranganathan. Dr. Ranganathan, what are the common situations, as DG sir has just said that like in the private sector, there's a lot of misuse that happens. What are the common situations for misuse and overuse of antimicrobials in Indian healthcare settings, particularly in the private sector, including individual clinics? Over to you, Dr. Ranganathan.
He's also on mute
Yeah.
right now.
Yeah, Dr. Good evening. Here. Can you please repeat the question? Missed out the question.
Yeah, I'll share your question again. So,
Yes.
what are the common situations for misuse and overuse of antimicrobials in Indian healthcare settings, particularly in private sector, including individual clinics?
I would say yes. So the first is systemic approach. Now,
Dr. Ranganathan, your audio
to
is not
treating
clear.
patients. Yeah, hello. Yeah, is my audio clear
Yeah,
now?
much better, much
Am I
better.
audible?
Yes, you are much better. Please continue.
Yes, hold your phone closer to my face. Okay. Now, well, in the private sector, people do talk about following a syndromic approach, which is very good, an approach to treat patients, and that is how patients must be managed. However, patients do go in for an upper respiratory tract infection, and most of the times, almost 90% of the times, all URIs are due to viruses. And patients get a host of antibiotics administered to them, particularly by a general, and these days even by specialist practitioners, particular both for adult patients as well as for children. And in children, it happens even more because the parents are anxious and they want their child to get well as soon as possible, because it hampers a lot of other activities at home. They need to go to work. They don't have somebody to take care of their children at home who are sick. So therefore, there's a lot of pressure on pediatricians to start off some antibiotic so that there is help. And the other very important thing is a prescription is written the first time for a sore throat in a child. Now, I have seen this happening at our hospital itself, that these parents take that prescription. The first time they take an azithromycin or an augmentin syrup, which is prescribed, and they give it to the child gets well. And then they come back, they don't even come back to the pediatrician, to the hospital. The next time when the child has another sore throat, out comes the same prescription, and they go to the pharmacy and they get the same antibiotic and they give it all over again without consulting a pediatrician, without consulting their family doctor. Nothing is done. So, so it's basically a lot of parental pressure, a lot of pharmacy pharmacies are allowed to give out antibiotics without a dated prescription. That is another factor that helps that misuse and abuse of antibiotics. And many a times, of course, cultures don't give out any accurate or proper results. And that is another reason why antibiotics are just empirically chosen. And preemptive antibiotics are literally given off to patients and they're sent home. That is because, particularly in pediatrics, I work in an obs-gynec in a pediatric hospital, and there is a lot of pressure from the parents and from the family members to get a child up and well as soon as is possible. So these are some of the reasons why in the private sector, yes, the private sector does contribute to a lots more of misuse and abuse of antibiotics as compared to the government general hospitals. Definitely, yes. I do agree with Professor Kapoor.
That was Dr. Goyal's response, which I took forward.
Yes,
So,
sorry, Professor Goyal. Atul Goyal, yeah. Professor
Yes.
Goyal.
yes.
I do agree with him.
Thank you. Thank you so much, Dr. Ranganathan. So now I move on to another question, which was a point which was raised by our DGHS, which was about education. And so we all agree that education plays a very important role in clinical practice. So my next question is to Dr. Sumit, how do you think the current medical education is placed? You know, is our current medical education content adequate for educating our young doctors on judicious use of antimicrobials? Even if the MBBS and postgraduate doctors are educated on current crisis of AMR, how much is the impact of inappropriate antibiotic prescription by the seniors that they see on a day-to-day basis? Over to you, Dr. Sumit.
Thank you, ma'am, for inviting me for this very prestigious and a very important webinar. Coming to the first part of your question, whether the current medical education is adequate, so I would say no. And I'm not the only one who's disagreeing on this. In fact, on the contrary, it's become worse since few years before. Earlier, we used to teach the cause, effect, and the cause cycle. That means you talk about first, we'll talk about a case. So in that case, the causative organism is Staphylococcus aureus. Then we'll talk about its pathogenicity, its toxins, its antibiogram, how it grows, how it looks like, what are different media, and all these things. We'll tell them how the treatment also, and then come back to the same case, referring like that. So it was a complete cycle was there, the cause, effect, and the back to the cause. So now, for example, I'll just give you, we recently gave a question of a skin and soft tissue infection to the MBBS students that, a wrestler has come with a typical history of community-acquired MSSA. So that's the history that we had. But they all diagnosed it as a case of a herpes gladiatorum just because he's a wrestler. So because we are teaching only the syndromic approach only and not the causative organism. So they are not absolutely serious about what is the real causative organism. And I am not the only one who feels like this. Among all the clinical microbiologists, they feel almost the same way. That normally we used to start a didactic lecture with a case and then come to the organism, then with the pathogenesis, prevalence, clinical signs, symptoms, lab D and everything. Now, with no idea about the pathogenicity of the organism, the students are absolutely clueless and they can take any provisional diagnosis as a definitive diagnosis. And there's a huge confusion among the students which diagnostic technique is to be used where. Especially they will start writing everything post-COVID, everything they'll put up RT-PCR in every answer. And now they start writing MALDI-TOF in every answer. They started diagnosing for viral infection also, for virology also, they'll put up MALDI-TOF. For parasitology, they'll also put up MALDI-TOF. So what we do, what I have advocated in my lectures is at least that at the end of the lecture, we have a 5 minutes time is there to take the attendance. So during that time, we focus as the slide on the good and the bad antimicrobial stewardship practices that are focused like the snakes and ladders game that we have made on the screen while the students gaze at it, and we repeat it in every lecture. So at least they are able to see what are the good and bad practices, and another slide we replace it with the 5 modes of hand hygiene. So yes, as of today, the current medical education is not at all good to teach them the actual cause. So they don't understand what is the seriousness of the organism. So that is not enough for the doctors today. And the second part of the question is that, like, for example, the cord needs to be broken. The cord that is there between the junior and the senior, because that is what is happening. The wrong information is constantly being teleported, transported from the seniors to the juniors, and it's natural for all the juniors to aid the seniors what they're doing. So if the seniors have wronged it, then it will be replicated in the juniors also. Again, I'll give you another example. When I was in one of the institutes as a faculty, one faculty approached me that two of their cases, elective cases of maxillofacial carcinoma, died of MRSA infection after an 8-hour surgery. So I asked him, what did you use as the surgical antimicrobial prophylaxis? He said that we are using ceftaroline. So I asked him that ENT surgeries normally require gram-positive coverage and not gram-negative. So when I asked him why, he said just because the senior is doing it. So yes, there has to break in the. We have to erase what has been the wrongs that have been done so far, and we have to start afresh like that.
Yeah, thank you. Thank you so much, Dr. Sumit, for that response. So I think one of the, as Dr. Sumit has already highlighted that, what we see, the younger generation of our doctors are following that. So my next question is to Dr. Aravind. Dr. Aravind, what should be the correct practice for prophylaxis while conducting surgeries, obs and gynae procedures, such that it does not contribute to emergence of AMR?
Good evening, everyone. I'd also like to thank Rebecca Pur Madam and Atul Goyal sir for giving me this opportunity to be part of this elite panel discussion. As Madam said, so when we are looking at the stewardship strategies adopted at the hospital level, so one of the low-hanging fruits is actually with regard to the preoperative prophylaxis. It is the surgical to prevent the surgical site infections. Despite being a low-hanging fruit, what we have observed, even in my hospital, maybe when we started around, say, 10 years back, there are a lot of issues with regard to the optimal use of preoperative prophylaxis. So optimal use means, we need to have a written down plan regarding what sort of antibiotic has to be used for what surgery. So like you means classify surgeries into clean, contaminated, dirty, like that. For clean surgeries like a thyroidectomy, so you don't require an antibiotic. But at that time, it was very difficult to convince surgeons regarding. So in clean surgeries, you don't require antibiotics, or obstetrics and gynec practices, hysteroscopy, then home retrieval. So some majority of the biopsies and all don't require any prophylaxis. So basically, when you're starting with the stewardship program, we need to identify that one of the low-hanging fruits is with regard to the preoperative surgical prophylaxis, and you need to have a written down plan and which surgery you can use which antibiotic. The second major challenge was the timing of administration of antibiotic. So, in the beginning, is 10 years back, the anesthetist, they never used to allow antibiotics to be given in the theater. That is, ideally, this antibiotic has to be given, say, within 60 minutes of skin incision. So the practice used to be that, at the time when the patient is being made ready for surgery, just at 7 o'clock in the morning, etc., the antibiotic will be given. And then the patient is taken up for surgery at, say, 1 o'clock or something like that. It does not serve the purpose it is meant to do. That is, at the time of incision, you need to have an adequate tissue level of the antibiotic. So then, over the next 2 to 3 years, we were able to convince everyone so that, the right time of administration of the preoperative antibiotic was ensured. Then there are situations like, cardiothoracic surgery and all. Probably you may have to go for, say, more than 24 hours of post-op prophylaxis as well. Situations where, the length of the surgery will be more than 2 times the half-life of the antibiotic that we are administering. Then we need to give a second dose of antibiotic. Situations where, the blood loss will be more than 1.5 liters. Probably in such situations also we need to give the second dose of the antibiotic, etc. So basically, from my experience, now what we understood is that Nadal Goyal sir also did say that, one hospital doing it properly does not mean much. So all the hospitals in the state and the country need to follow the basic stewardship practices. So one such practice is actually preoperative antibiotic prophylaxis. So we understood that the best way is to insist that the surgical safety checklist by WHO, and one component of the surgical safety checklist is actually the timing of the preoperative antibiotic and when this should be stopped, etc. So as part of the antibiotic smart hospital initiative, one component is that all the hospitals in the state of Kerala, they should be following the surgical safety checklist, which ensures that, the antibiotic is given, say, within 60 minutes of skin incision. So it is not being continued for more than 1 dose, except in cardiothoracic surgery, etc. So basically, a written down plan is necessary. We need to engage with all the surgeons regarding the right time this is to be administered. the right duration of administration. You cannot, if you are continuing more than 1 day, this is not a prophylactic antibiotic, it becomes a therapeutic antibiotic. That's about it, madam.
Yeah. Thank you. Thank you so much, Dr. Aravind. And certainly, as Dr. Aravind has highlighted, it needs very strict discipline, and it also requires very good written protocols, which everybody agrees to and follows. So my next question is to Dr. Sumit. Dr. Sumit, what are the common challenges faced in optimal utilization of laboratories to guide evidence-based use of antimicrobials? And how can labs ensure that they give out quality results? And how to, and that of course also results in building trust of clinicians in the lab. So please would you highlight or throw some light on what are the common challenges faced in the optimal utilization and of labs to guide evidence-based use of antimicrobials, and how to build trust of in among clinicians on the laboratory results. Over to you, Dr. Sumit. Dr. Sumit, you are on mute.
Yeah, okay, sorry. So actually, first of all, is that the labs themselves have to feel worthy enough to make themselves available for their optimal utilization. So lab themselves have to be worthy enough. Like for example, I'll give you a very typical situation, and and what I'm going to tell you is probably going to be a little hard hitting also, because when we say that you never expect the last batsman to score a century. So normally what we think that everybody who's coming into microbiology, it's not their first choice. So most of the people who are coming there, they're taking it as a second choice or the third choice. So many of them, they lack that will to build up a lab like that, which would be giving the best utilization to the clinicians. So the question is that how many PGs are taking up microbiology, how many are completing their entire thing. Most of the people don't even think that's a clinical branch. So unless this mirage is not broken, how many PGs, there are many PGs who take up ID just to don the there is such a scope also. So the issue is that there is no ownership. Unless there is no ownership, this mirage is not broken. The mirage is that people think it's a non-clinical branch. The fact is it's a very much a clinical branch. You start your 24/7 lab and then you'll realize how clinical it is. The moment you immediately start getting samples, you start giving them a Gramscian report, you start giving them the rapid AST, and you start visiting the rounds, you start visiting the clinics, you'll realize that it's a clinical branch. So unless this mirage is not broken, that this is not a clinical branch, this will happen. So unless you feel empowered, then only you can make it. So you have to break that. So the stakeholders have to have that actual ownership that yes, we can run a 24/7 lab, and the stakeholders in clinical microbiology and infectious diseases, they until unless they themselves are not serious in making their labs optimally available. So first thing is that you have to make your lab a 24/7 lab. That is goes without any fail, and that lab has to be built inside the hospital next to the emergency, and we have done that only in our institute. Ours is a 24/7 lab running next to the emergency. It's barely 30 seconds away from the emergency. And of course, many administrators, they need to empower the clinical microbiologists. Many administrators who are sitting at the helm of affairs, they think that like biochemistry, microbiology also has a system of automation is the same as auto analysis. No, it is not like that. Automation is not the same as auto analysis. For the optimum utilization in the lab, we not only require the machine, but also the manpower also. So AI is coming there, but it's not that AI can no, replace the clinical microbiologist. And so that's why in the pre-analytical part, the clinicians also have to be made aware that for the optimum utilization, they should know that what is the best specimen to be sent for which kind of specimen, for which kind of investigation. And that coordination has to be given by the microbiology department, and training has to be given that under what circumstances, what kind of syndrome, what kind of sample has to be collected, how. So the pre-analytical part is very, very, very critical in clinical microbiology and infectious diseases. So what kind of specimen we are getting, whether it's a pre-antibiotic or post-antibiotic specimen, what is the quantity, what is the quality, what is the transportation, storage, the frequency of collection, it's not known by the clinician. So unless all these things are not trained, though they cannot utilize the lab optimally. And of course, the nursing cadre also. The nursing cadre has to be trained that before they take specimens for investigations, they have to draw blood culture and they have to draw the specimen for cultures as soon as possible. And all they have to they have to be the pre-antibiotic samples. Then another issue is that the cropping up of many of these so-called path labs. So these path labs, they are also providing, they are run of the mill kind of labs, and they have got some person who's appointed there as some microbiologist who's not even qualified enough to sign an AST report. He could be a pathologist. He could be anybody. So these are the issues that that keep us away from utilizing the lab properly. Another thing is that how can we ensure quality in the lab? So yes, one word that is expected from everybody is enable accreditation. Now, there can be no quality, and because I'm saying it after assessment of almost 150 plus labs, being an enable assessor, there can be no quality without ownership. Until unless you don't get ownership, you cannot create quality. You may get enable accreditation, but enable assessment is just a point prevalence or a single observation survey. It is not spread out over a duration of many months of observation so that they can find out what are the actual NCs that are there, what are the actual problems which are there. So it's only the integrity of the lab head, their ownership, their competency of the each faculty, resident, technical staff, and like I said, after assessment of so many labs, one common factor that maintains and sustains quality is ownership by each and every member of the organization. Like in our department also, the dictum is that we don't use this phrase that this is not my job. A person like me also will get up on the slab and put up a tube light on my own if the electrician does not come in half an hour time. So it is not like that this is not my job. We don't use this phrase in our department. So everybody has taken the ownership, everybody is accountable, and ownership is required for the sustenance of quality. Of course, the competent person must be put in the right location for the right job. Like for example, what has happened is like you place me in a recruitment cell or a procurement cell, I will not only do injustice to that designation, but I won't have time for my own lab also. So you have to have the competent person at the right place with the will and with the willpower and the ownership and that kind of, you can say, the vision to take the lab ahead. So quality is the only, and ownership and the integrity, that are the main features which are required to be quality results. After that, the enable follow. And enable is a plethora of multiple things which most of the attendees will already know what enable is doing. So like you have to have competency, you have to have good equipment, you have to have good maintenance, you have to have a supply chain management, multiple issues are there. So these are the input from my end. And if you say that how do I build trust among the clinicians? So there are only three words, that is communicate, communicate, and communicate. So as much as communication is possible with the clinicians, that only builds up trust. You have to call them, you have to text them, you have to WhatsApp them. We need to lower the turnaround time for the critical specimens like CSF samples, blood cultures. We do rapid and direct ASTs now that we have got the multi-TOF also. Strictly abide by the CLSI or the UCA standards. We have to give them critical alerts and perform direct microscopy on every sample whenever and wherever possible, irrespective whether the gram stain or a direct microscopy has been raised in the form or not. Next is our 24/7 lab, which I've already mentioned. So with fully automated equipment, continuous blood culture monitoring system, CBNAT and Formulary, and a competent manpower. Besides, we need to have clinical rounds by the microbiologist so that we have daily interaction, especially for the serious patients. Right. Those are input from my end, ma'am.
Thank you. So thank you, Dr. Sumit, for a very detailed and a very accurate and very apt reply. So as Dr. Sumit has said that their 24/7 lab is next to the ICU. And we all are aware that ICUs are the places where we have a lot of MDR bugs. And the excessive use of antibiotics further contributes to emergence of MDR pathogens. So I wanted to ask Dr. Arvind how to prevent the just-in-case use of antibiotics, particularly in the ICUs.
But that's actually a very a tough question because the excuse usually given by people who work in the ICU is that they're not really confident about the IPC practices. So basically, this since they are not really confident about IPC practices, in order to cover the inadequacies of IPC, so they end up using antibiotics Okay, and this will lead to selection pressure and will lead to the genesis of alteration of this thing, gut microbiota, collateral damage, and more resistant bugs. So this used to be the situation, and now we know that we have a theragnostic model of antimicrobial stewardship where the three pillars are equally important. There's infection prevention and control, antibiotic stewardship, and diagnostic stewardship. So around say 10 years back when we started with all this stewardship in my institution, the thing that we did first was to engage with those who are working in the ICUs, especially the critical care people. And I'm very glad to say that now they are the stewardship champions in the hospital. So you need to, as Sumit sir said, we need to communicate with everyone who is actually prescribing the antibiotics, especially so in the ICU because they are the hub of resistance. So, in the West, when we are looking at the data, only 30% of the patients in an ICU is getting an antibiotic. But when you're looking at the Indian scenario, I don't think, patients in the ICU, anyone will be without an antibiotic. But then, once we strengthen our IPC practices, the doctors who are working in the ICU, they gain confidence that the healthcare associated infections can be prevented. So may it be infection ventilator associated complication or say CLAPSI or COTI, with the bundles of care or practice, we can prevent an infection from occurring. If you're giving that much confidence to the treating team, definitely then we can push the second part of the stewardship forward, that is antimicrobial stewardship, along with the diagnostic stewardship. Regarding the diagnostic stewardship part, one thing is very, very important because if you are not having a trained physician in the ICU, and if the patient is developing fever, so they have the habit of sending something known as the bus culture. So bus means blood, urine, and sputum together. Okay, and if the adequate amount of blood is not sent for culture, and urine, the microbiologists may not report the result, they will ask for a repeat sample. Whereas the sputum, they might end up reporting. The patient may be having something else, and since the sputum grew Acinetobacter or Klebsiella, the critical care person might end up starting an antibiotic. So this is what happens in majority of the ICUs. Here, what we really do is, if actually our microbiology lab grows something, they definitely discuss with the clinician out there regarding, do you really suspect an infection-related ventilator-associated complication? Does the patient have features of ventilator-associated condition? If that is not there, they won't report the result. So this is diagnostic stewardship. So if diagnostic stewardship is practiced perfectly in almost all the IP as well as ICU settings, I believe that we can actually come down on the antibiotic use by around, say, 50 to 60% in majority of the settings. And then if our infection prevention and control is also top notch, then also our clinicians will gain confidence so that they will resort to whatever we say. But the most important thing is, without educating all the stakeholders, we need to educate the microbiologists about diagnostic stewardship. We need to educate the ID people about the reasons why the critical care people are resorting to overuse of antibiotics. We need to educate the critical care people about identifying the reason for the fever and not just send all the cultures together. So if all these things are in place, but takes effort, you need to train everyone, including the critical care nurses. So what we did is, based on our carbapenem resistance rate, we have around 23 ICUs. Based on our carbapenem resistance rates, we actually classified our ICUs into high priority, low priority ICUs, because all the hospitals do have logistical challenges, even though we dream about having, say, 1:1 nursing and all those stuff. So it is not practical in the Indian situation. So what we did, based on our carbapenem resistance rates, so we identified some ICUs as a high priority ICU. In the high priority ICU, so we actually ensure that the nurse to patient ratio is optimal compared to the other ICUs, so that our hand hygiene compliance and all the bundles of care are optimal there. And we ensure that only the critically trained people, that is not only the doctors, the sisters are trained in critical care nursing, so that there is no breach in IPC practices. And we won't entertain any reliever in a high priority ICU. Sometimes some sister will be on leave and someone who is working in the ward may be posted there. So we don't want that to happen. So we engaged with the administration and said that in the ICUs, we can't just have a person who is not trained in ICU practices be posted there in the evening or something like that. Because one breach means the patient will get a carbapenem resistant Acinetobacter infection. So basically, since, if you're looking at, say, the national antibiogram, ICMR antibiogram, etc. So carbapenem resistance is around 80 to 85%. And state antibiogram is around 75%. So if you have a breach in IPC in the ICU, it is going to be a carbapenem resistant Acinetobacter. So when we are looking at all the three pillars together, And actually, all these clinicians are also part of the monthly infection control meetings where we present the antibiograms and color coding of our ICUs, etc. So means that, as Sumit sir said, it is a teamwork. It is not just the clinical pharmacologist or the ID or the microbiologist. Everyone has to be in it together. It's not a blame game or anything. So we are in it together so that, we can optimize the outcome of the patient. And we also will be the patients in the same ICU in future, right? So whatever we are doing is actually for ourselves, our relatives, our patients, and the future generation. So if we are actually conveying the message of teamwork, then we'll be able to convince the doctors not to use antibiotics if it is not required. But without actually strengthening the IPC practices, without strengthening the diagnostic stewardship, if we say that you should not be using an antibiotic, then I don't think they are going to listen to you.
Yeah, thank you so much, Dr. Arvind. That was a very elaborate response and very good, inputs regarding which can be applied in our day-to-day practice, and how I think communication comes out as a very important point, between clinicians and the laboratorians. So now my next question is regarding our theme for today, that is antimicrobial stewardship. So which is one of the very important ways how we could optimize prescription practices. So over to Dr. Sumit. What is the Antimicrobial Stewardship Program and what is its importance in promoting judicious use of antimicrobials? And second part is, what kind of resources are required to implement a functional AMS program? Because many people feel that if we don't have an ID physician, we cannot implement an AMS program. And thirdly, what should a healthcare facility invest in? Why should a healthcare facility invest in establishing an AMS program? Over to you, Dr. Sumit.
Thank you, ma'am. So regarding the first part of your question, what is antimicrobial stewardship? So just recalling, last year I was invited for a talk, and I was just talking about stewardship on the stage, and later on I got a feedback from the head of the department of surgery. He said that I didn't know what is stewardship. So even people who are doctors, who are specialists, super specialists, unfortunately, as of today, also don't know what is the meaning of stewardship. So any step, any small step, any big step that is taken towards the judicious use of judicious diagnostics and the rational use of antimicrobials is basically stewardship. I'll just give you an example that if you, for example, if you just walk into a restaurant and you ask the waiter that what is the menu, he'll give you a standard menu. So it'll have a standard food and everything. So you just order and he'll get it for you. What actually a steward does, and that's the term that is used in the good quality restaurant, is that they customize the order as per your taste, as per your liking, as per your medical conditions. You want vegetarian, non-vegetarian, your preferences. You want chilies, you want salt, whatever it is, your ethnicity, whatever it customize. They customize your entire food for you. Similarly, stewardship is basically an integrated approach, and hence we should call it integrated stewardship. Like Ramit sir has already mentioned that there are actually three pillars of the stewardship. The integrated stewardship that we call it basically has got four components. One is the antimicrobial stewardship, second is the diagnostic stewardship, and third is the infection prevention and control stewardship. And the fourth and the most undermined and underrated is the community stewardship, that I'll just talk about that also. So specifically, antimicrobial stewardship is talking about like what are the drug choices we have, what are drug dosing, what is the antibiotic posology, what is the PK/PD management, what should duration of the antibiotic, what should dose on the antibiotic, what is the breakpoint to MIC quotient, what is the prescription auditing, adverse drug events and adverse drug reactions, consumption auditing, and all these things, they are all part of antimicrobial stewardship. So they can be performed either by the physician or by the microbiologist or by the clinical pharmacologist. Anybody can be a part of the antimicrobial stewardship component of the integrated stewardship plan. Then is a diagnostic stewardship that involves the active reporting, that is 24/7 reporting, automation, quality control, interlab comparisons, external quality assurance, lab accreditation, emergency reporting, 24/7 critical alerts, and then interpretation with the clinics. So it is integrating in the sense that what we get, we just don't report it. We have to first look at the patient. So we have to look at the patient follow-up. We have to look at the pre-analytical issues, because we get many times a huge heavy growth of E. coli, but there are no pus cells, there are no bacteria in the specimen. So it is most likely a contamination, probably because of delayed transportation. Then there are a lot of clinical footnotes that we put up in our AST reports, intrinsic resistances, and extended antibiotic panels. Like, for example, we put up a CRE panel specifically, or the collagen broth disc illusion testing, all these things we are doing. So this all a part of diagnostic stewardship. Third is very obvious, the infection prevention control stewardship, involving the hospital surveillance and hand hygiene and outbreak investigations and all these things, and especially involves a lot of training also. The fourth component that is quite undermined, and I'm very happy to say that it's being done very nicely in AIMS Bhopal by Dr. Sagar and AIMS BB Nagar by Dr. Rahul. And the recent example in Kerala, where home-to-home awareness was created on about the menace of the AMR. So these two aims, they are doing a lot of good work on community stewardship, and this is a very untapped resource, which is the Department of PSM, or the Preventive Social Medicine, or the Community and Family Medicine, where they can actually have an outreach program into the schools, which are the untapped areas. Like, for example, in my previous institute, I had made a kids project, KIDS kids project, standing for Kids Infectious Disease Surveillance Project. So how to deal with a common cold, don't take antibiotics, hand hygiene, children to be taught, and like things like, even most important is that to have visits to the chemist for the over-the-counter use of antimicrobials to control those things. So like DG sir had said that, and even Iyer sir also said that they take the previous prescription and they repeat the same thing again and again every time the child gets a cold. So since past 6 years, a group of physicians, surgeons, clinical microbiologists, pharmacologists, we all have been functioning as a very coherent and a very adherent group to raise awareness on AMR and AMSP and its solution through integrated stewardship by encompassing all these components of now the 4 components: antimicrobial stewardship, diagnostic, infection prevention, and community stewardship. So we are doing it through a registered society called as SASP, Society for Antimicrobial Stewardship Practice in India, and it involves all the INIs at this moment. But we are in the process of involving as many hospitals so that and it includes everybody. It includes physicians, surgeons, microbiologists, pharmacologists, everybody. So that is all about the antimicrobial stewardship, or we would like to call it as integrated stewardship, and that's why we call our lab also as the integrated stewardship lab, because in microbiology we don't just report that sample has come, this is the bug, this is the AC. No, we correlate the clinical condition and then only we report it. That's why we integrate the biochemistry, pathology reports, even the radiodiagnostic reports also in our lab. When it comes to the resources which are required to implement a functional AMS program, so there's always the CDC checklist available. CDC checklist for the core checklist for the implementation of the AMS program, and you can customize it as per the institute. But always one thing is there, that you have to, when you're starting an AMS program, or even if you already started an AMS program, aim small to miss small. So that means you have to aims don't try to implement everything at one time. First of all, let's start with leadership. Convince your director, convince your MS that an AMS program is essential, and it has always also been you can say implemented through the NMC also. Now, the irreplaceable, or you can say the non-physical entity which are required for the implementation of functional program, you might get any amount of equipment, but what you really require is willpower, you require passion, you require ownership, you require leadership, you require vision. So first thing is that you get a leadership support. So like I said, the moment I joined this institute in 2021, within a month's time, I got the antimicrobial stewardship committee made by the director, with the director as the leader of the committee, as the chairman of the committee, so that whatever the director says, that will definitely be implemented. So that vision has to be there. Then among the physical entities, the resources, that is a 24/7 fully functional integrated stewardship lab, where all the 3 components, excluding the community, of course, all the 3 hospital components of the stewardship are included. And it has to be inside the hospital. Most people, they make microbiology is a paraclinical branch, make it in the college, hospital is different. So never do that. Always put up your lab inside the hospital, close to the emergency and the IPD areas, and preferably close to the sample collection center, because the transportation of the sample is very, very important. At what temperature is being maintained, how much time you're taking to transport a sample. So pre-analyticals are very, very critical in clinical microbiology infectious diseases. The entire history, the entire interpretation changes if the sample delay is there. So automation definitely helps, but AMS can also be done in the absence of stewardship. So like I said, any small step taken towards the judicious use of the judicious diagnostics and the rational antimicrobials is stewardship. Now, if we actually talk about what are the investments that we have to really make to establish an AMS program. So we should I know that in the private sector, we have to look at the cost. But then if you ask me, in the ideal world, you should have a competent, trained and determined manpower, most important. Organized antimicrobial stewardship team with a clinical microbiologist, a physician, any AMS steward, a diagnostic steward, IPC steward, clinical pharmacologist, or a pharmacist, ID physician, all should be involved at once in the AMS team. And everybody has to have a role, and there should be proper organogram for the AMS team. Most important is the IT support, because when it comes to the the calculations of the metrics, the calculation of the consumption of the antimicrobials, all these things will require a lot of computers and related paraphernalia with a good HIS, HMI that it's integrated with the sample collection facility, and preferably all hospital areas that raise the investigations with the admin rights for us to see all the reports from other departments like radio diagnosis, biochemistry, and pathology, etc. Then, of course, not to mention, yes, definitely automated equipments are very, very important, like automated blood culture machines, automated ID and AC system, automated media preparator, automated anaerobic system, Malditov, film arrays, CBNAT systems, light microscopes, fluorescent microscopes, RT-PCR, CLIA machines, alpha machines, and not to mention the other miscellaneous machines like incubators, refrigerator, DPs, and lyophilizer, of course. So these are the things which are actually required to establish a good lab for a formidable AMS program.
So thank you, Dr. Sumit. I think Dr. Sumit has given us both options to have a complete range of lab, and also one can start with a small lab, but one has to be committed. I think that's what he's trying to say. And I think we've also seen that that once you start performing and you start sharing an importance of the laboratory, the administration does not mind investing in the lab. It's the other way around. We may keep waiting for the administration to give us everything and then we start, but that doesn't happen that way. We need to first, show the great, requirement of our laboratory by the clinicians, how important it is, and then gradually administration also starts investing in the lab. Okay, we go to the next question, which is to Dr. Ranganathan. Dr. Ranganathan, we just heard from Dr. Sumit about the importance of antimicrobial stewardship program. And one of the components of AMS program is developing an antibiotic policy and in a healthcare facility. So what is the compliance as per your experience to the antibiotic policy of the hospital among doctors, and how can the compliance be improved? Dr. Ranganathan.
Am I audible?
Now you are, yes.
Yeah. Well, the first and the foremost thing is to have an antibiogram which is clinically relevant, and that's the most important thing about an antibiogram. Many times we do have organ.
Dr. Ranganathan?
Yeah. I just keep going out and in, out and I don't know what's happening. So the antibiogram is clinically relevant for it to be. That's the first and foremost thing. And then once it is clinically relevant as an antibiogram, then the antibiotic policy can be made based on clinical presentations, based on what is expected to be seen, what one would expect as an emergency admission to the intensive care unit, to the wards, and so on. What are the common presentations that is done? Because one of the foremost needs for any clinical department with respect to an antibiotic policy is, what do I start as an empiric therapy for a particular patient who gets admitted to the hospital with this particular symptom complex, with this particular syndrome, with this particular set of clinical features. Now, if that answer is not given in an antibiotic policy, it's really not an antibiotic policy. It's not clinically relevant. And we can't expect our clinical colleagues to follow such a policy because they would say it's not helpful to me, so I might as well do whatever I think is right for my patient. So we need to have discussion, sit with them with our antibiograms, sit with them, understand what are the various clinical presentations which they come across, and then try and work out an antibiotic policy in every situation. That's got to be agreed upon by the clinical department concerned. And then alone can one expect them to follow it. And then, of course, I mean, we would have varying degrees of resistance from clinical colleagues. Some of them are very compliant, some of them are partially compliant. Some of them say, oh, I meant, yes, on that particular day we had a problem. One of my clinical colleagues, yeah, I mean, he doesn't follow this. How much ever I tell him, he doesn't follow. So, I mean, there are some lot of hurdles which we need to cross when we need to cross the river and the ocean of antibiotic resistance. And then finally, there will be some who would say, do what you want. I will not follow this. I know what is good for my patient. Who the hell are you to come and tell me what I should be doing? And this usually comes from surgeons. So I mean, they do not know much about antibiotics, but they would definitely dabble with antibiotics, and they would also interfere in the intensive care physician's role and say, no, why don't you start this? My patient who is operated is not doing fine, so please start this. So I mean, one must expect to find varying degrees of resistance, and I mean, when we talk about compliance to an antibiotic policy. But then if we make friends with them, sit with them one-to-one and discuss the antibiotic policy, the need for it, and understand their problems in implementation, most of the times I found them to be compliant. The most compliant people are the neonatologists. They are followed by the obstetricians, followed by transplant surgeons, and the least compliant are the pediatric ICUs among the pediatricians, because they do see a range of conditions, and sometimes some of the clinical conditions are very, very, very life-threatening. Another very important hurdle to implementing an antibiotic policy is when we get too restrictive and we say no. In every single clinical situation, you will do only this. Mm-hmm. Now, a very important thing about implementing an antibiotic policy is one cannot interfere with treating a life-threatening situation. And in those cases, one must say, okay, fine, let's let go and let them do what they want to save a particular child or a patient. And then we will come back tomorrow morning and discuss with them how we could de-escalate. So these are some of the things which could be done to make people more compliant, more reasonable to accept an antibiotic policy and say, yes, we will, I mean, we are with you and we will do what can be done.
Thank you. Thank you so much. Thank you so much, Dr. Ranganathan. So I think as shared by Dr. Ranganathan, we need to continue to build our communication and also in critical situations, understand each other and move ahead. And perseverance, I think, as he has pointed out, is very important. So we go on to our next question, which is to Dr. Sumit. So Dr. Sumit, though partly we have already discussed this, but I would like to ask you that what is the role of a microbiology laboratory in establishing, like many times the clinician is not able to take a lead, though it should be the clinician, as you said, it should be a team, we should be establishing the MSV program. But what is the role that microbiology laboratory can play in establishing antimicrobial stewardship program at a healthcare facility?
So as ma'am already mentioned that the integrated stewardship has got 3 hospital components and 1 community component. So the role of the microbiologist comes over in all the 3 components, especially the diagnostic component, followed by the infection prevention control component, and of course the antimicrobial stewardship component. So because the microbiologist, because we are dealing in infections and we are the centric to the very concept of infectious diseases. So first of all is that the 24/7 lab has to be there. That should be made mandatory. That should be made mandatory inside the hospital, next to as close as possible to the emergency or the ICU areas, because this 24/7 lab can receive and process the pre-antibiotic sample. So like I always say that if infections don't take a break, then why a microbiologist should take a break? So at least the microbiology lab should be 24/7 and they can process the pre-antibiotic sample. So if you want to implement the order of draw in the sample collection areas, So, and if you want that 40 ml of sample have to be sent and 4 bottles and 2 sets have to be sent, so you have to make your lab also available. So first of all is 24/7 lab should be made mandatory wide across the nation for clinical microbiology. That's one thing. Secondly is gram stain findings or the direct microscopy findings can also be provided immediately for the diagnostics also. So whether it's inflammatory sample or a non-inflammatory sample, that can be determined by a direct microscopy and a gram stain that can be immediately provided by the lab also. Next is we do a tiered level reporting for the blood cultures. Like for example, the moment the blood culture comes positive, we have got a long list of critical alerts for blood cultures, for biogenic samples, where we're getting CRE patients. So we have got a huge list of critical alerts. The moment we find that critical alert, we immediately call up the clinician or we send a WhatsApp. So that's the documentation also. So the tier one is that the moment a blood culture flash is positive, we make a gram stain, and if it is a gram-negative bacilli, definitely it's likely to be pathogen. We call and inform the ward immediately that there's a GNB is growing. Next is that we put up the direct AST for that, the rapid AST for the GNB. After 6 hours or so, or 8 hours or so, as per the CLSI protocol, the moment the direct AST comes, we can tell approximately that, yes, okay, meropenem seems to be susceptible. You can start meropenem and maybe later on de-escalate according to the final AST report. Then the third tier reporting is the what we do with the Vitek and the curveball distribution. So we're putting up both of them. We're putting up both the automated AST as well as the manual AST for especially for those antimicrobials which are not there in the automated panels. So that is the third level reporting, and especially for the blood cultures, we send a breakpoint to MIC quotient based reporting, and then we tell them on the report also that this is the best possible antibiotic, this is the dose. You may give a combination, and if you're giving a combination, which should be given first, which should be given later on, whether those two drugs are Y-site incompatible or compatible, that also we mentioned in our reports. What should be dose and duration in that particular patient, that also we mentioned in our reports. So a good quality customization of the final AST report has to be done. So because these reports are not like your biochemistry report that this is sodium, this is potassium, this is the printout, that's it. No, it's not like that. There's a lot of customization which is required for the AST reports, and that is what we are teaching in our advanced AMS workshops also. Then important part comes the cumulative data, because we are entering all our data in real time on WhoNet. So we always have a presence of a real-time cumulative antibiogram. So we can provide cumulative antibiogram for the hospital antibiotic policy. Then we have got a stratified antibiogram also, rolling antibiogram also we can make. Then we have got syndrome-specific antibiograms. We can make antibiograms as per the wards also. We can make consultant-specific antibiograms also we can make. Then combination antibiograms, that if I have an option of choosing meropenem as a monotherapy or piptazo and amica as a combination therapy, this combination will work. What are the odds that this will work better than a meropenem monotherapy? So that combination antibiograms also I can make on my WhoNet also. Then of course, when it comes to the IPC, we are the lab will monitor the HAI surveillance and hand hygiene audits also we're doing. So for the infection control, we are doing our monthly presentation of our HAI surveillance for a CLABSI, COTI, CRBSI, VAPS, and everything, hand hygiene compliance in the NSI also. You're presenting every month in the hospital infection. So we've got two separate committees. You've got hospital infection control committee separate and the antimicrobial stewardship committee separately. Then, of course, we have the rapid point of care tests like the biomarkers for a procalcitonin. We are yet to get one, but at least we are doing CRP right now. Then the rapid serological test, and the most important part is the ward round audit. So whatever the IPD reports, the inpatient reports that we are sending, whether they are 5 reports or 10 reports, so sometimes myself or my residents or the PGs will always go for a ward round for the audits. And what we have found in the audits, in the prescription audit rounds, is that the nursing staff, they are very, very eager to learn. Whenever we are standing next to a patient, when they say somebody's come from microbiology, at least the nursing staff, 2 or 3 nursing staff will come and say, if you ask them why have we given piperacillin tazobactam and metronidazole together, so said that the clinician has said so, but both have got anaerobic coverage. Why do you want peptides already have as an anaerobic coverage? Why you add metronidazole? So they are very eager to learn, and they ask us also in the ward round that, sir, please hold us some more and more programs for us to learn all these things. So these are the responsibilities and the role of microbiology lab for the proper establishment of and of course coordinating with the pharmacologist for the prescription audit, for the antibiotic consumption auditing also. That part especially has to be taken by the pharmacy and the pharmacist also. So in our AMSP team, we do have a pharmacist and a faculty from the Department of Clinical Pharmacology as well. So that is the role that we are playing in our at AIIMS Mangalgiri for establishing our AMS program.
Thank you, Dr. Sumit. That's a lot of work. And I think, as you said, it really requires a lot of passion. Thank you again for sharing. So I move on to my next question, which is to Dr. Ranganathan. Dr. Ranganathan, I wanted to ask you, in a small healthcare facility or, one unit in the hospital, it may be easier to start the antimicrobial stewardship program. So what would you propose to such facilities or units who have joined in today as the minimum requirements and the steps to initiate the antimicrobial stewardship practices or the program?
Well, it depends upon what kind of a facility we are dealing with. If it is a clinic and a small facility that is run only by a single person or max 2 people, then it becomes easier to talk to them and try and work out an antibiogram based on the cultures that we get and discuss the preparation of the antibiotic policy based on the population that they have. It's easier when you have an obstetrics clinic with labor room, an operation theater, and wards or private rooms for delivery of the patient. And you have a predominantly female population, and you know what all they can come across with. So you have normal deliveries, nothing else. And then if there is an episiotomy, this is what you would give. If it's a LSCS, this is what would go in. If it is a patient coming in with intraamniotic infection or chorioamnionitis, as we used to call it, then probably that's the antibiotic. The thing is more of a challenge when you come across a nursing home where you have a variety of patients with different clinical conditions getting admitted, and you have more than 2 or 3 clinicians coming in. They come, admit their patients, they just take around, call the nursing staff, bark out some orders, write some orders, which doesn't, most of the times it doesn't make sense to anybody except themselves. And they say, ye sab de do usko. And then they go off. And you don't see them till the next day. And then nobody knows what's happening. Why have they given? Sometimes they give a cross-reference to a nephrologist or a pulmonologist, and each ologist comes and gives their own set of antibiotics and their own antifungals and sometimes even antivirals. And then that poor patient is on a constellation of antibiotics and antimicrobials. There is nobody, no control. And many of these nursing homes, leave alone having an antimicrobial stewardship plan, they wouldn't even have an infection control plan. And there wouldn't be an infection control nurse. There wouldn't be anybody because they function with a perennial shortage of nurses. And they just try and get some work done and earn some money. So this is what most of our privately run nursing homes are all about. And to make matters worse, you have these clinicians who don't talk to each other, who don't consult each other. They just give references and they go away. So in such cases, it is even more of a problem because you wouldn't know whom to talk to, who is the primary care physician, who is the secondary physician, who is the referral physician. And it's quite a challenge getting all of them together to sit on one table and talk about the patient and then talk about how to cut down and de-escalate antibiotics. So, a small unit with a clinic, it's easier when it is run by one single person or 2 people maximum who call the shots so that you only have to talk to them. Whereas it's definitely a challenge, even if the unit is small, when you have to talk to a big setter, a huge number of people who are not going to listen to you very well. It's difficult to even get them online. And then it's even more of a challenge talking to them, making some sense out of the whole thing, because cultures are not sent in these patients. And there is nothing to go by except empirically started antibiotics, which just continues for days on end till they decide to stop it before sending the patient home. That's what happens. So there are challenges, but then yes, sometimes it is possible to put in an antibiotic policy in a smaller setup if it is run by one single person.
Thank you. Thank you, Dr. Ranganathan. I think that's absolutely true. And that's why we say what Dr. Sumit said, we should start antimicrobial stewardship small, maybe with a small group of people who really are wanting to make a change. And
True.
one should make a real effort to identify such people in our setups. And first of all, it's important for us to be passionate and, really want to bring a change. So thank you, Dr. Ranganathan. Now I go on to my next question, which is to Dr. Aravind. So Dr. Aravind, another very important action that we take as a part of AMS is prior authorization of restricted antibiotics, and however, it is the most challenging step. And already Dr. Ranganathan has shared a little bit about it. So any best practices that you would like to share, Dr. Aravind?
So I will start with what Sumit sir said, when we talk about stewardship, there are a lot of things to be done. And I will say that if you are starting now, the last step to be done will be, what is given in almost all the textbooks as the first step, that is formulary restriction or the pre-authorization. So formulary restriction is a front-end strategy. That means that the restricted antibiotics, like say, you can say colistin or fosfomycin or ceftazidime, avibactam, like that, the restricted antibiotics, only with the permission of the stewardship committee, you will be able to prescribe this antibiotic. The major drawback of this is that, the physician autonomy is being challenged. Like what Ranganathan sir said, who are you to ask me? So you don't want to face that question when you are starting your stewardship program, right? So, physician autonomy is challenged in the case of prior authorization. That is actually going to be the biggest issue. The second issue that we faced is that, since we have been working with all the clinical teams for the last 14 years or so now, they might listen to us. But the real issue is, suppose, one of our patients in one of our ICUs falls sick at, say, 2:30 a.m. and has developed shock. Okay. So as per, Anand's study, in septic shock, you need to start the right antibiotic within, say, 30 minutes. And if a patient is developing septic shock in an ICU, in any of the hospitals in India, if it is a healthcare-associated infection, it will be due to a carbapenem-resistant strain. So you will end up using a reserve antibiotic. And that too, you have to start within 30 minutes for optimal results. Okay. Or else the mortality will increase by 7.6% every 1 hour delay of starting antibiotic, like that. So what happens here is that, they want to start, say meropenem or so tigecycline or colistin, and they have to fill out this antibiotic order form. That is one part of this formulary restriction. Then they have to contact someone from the authorization committee and then get the signature, etc. So at 2:30, I don't think anywhere in India it is going to be possible to get someone to vouch for this. So that is actually the major challenge when you're talking about, formulary restriction or pre-authorization. But there are ways in which you can actually, implement this without putting in paper that the signature is required. So that is by establishing a guidelines where, in which situation you can use this tigecycline or say colistin or ceftazidime avibactam. So we have been having that. Our in antibiotic guidelines for Trivandrum Medical College, the last annexures is about how you are going to use the reserve antibiotic, even without getting signature or something from the antimicrobial stewardship committee. So if these features are satisfied, say your antibiogram says that no, there is more than 20% resistant to carbapenem, there is more than 10 or 20% resistant to carbapenem, it cannot be used as empirical therapy. You will end up using colistin, tigecycline, things like that. So all these things with regard to reserve antibiotics, when it should be used, is actually crystal clear. It is pasted in all the ICs. So they can follow that. Then what we really practice is a back-end approach. That is a prospective audit and feedback. That is, the doctors in the ICU are given the freedom to start whatever they want to start. Only thing is that, when the stewardship team comes for a round with regard to the usage of reserve antibiotics, so at 48 hours, based on the culture reports, you need to look at the CARES pathway. So, if there is no evidence of infection, you have to stop the antibiotic, de-escalate the antibiotic, sometimes escalate the antibiotic, IV to oral switch, OPAT or COPAT, like that. So that is not actually formulary restriction. It is prospective audit and feedback that is being practiced in majority of the hospitals where there is a stewardship program. Second part of the madam's question is with regard to the best practices. So I will say that the best practice will be, a long duration of engagement with the clinicians, so that, when the reserve antibiotics are being used, they will actually contact you. It may not be possible at 2:30 a.m., etc. That is why we are having customized order plans, like, otherwise, they will contact the ID department because now ours is a hospital which have been having ID department for a long time. So they will ask us regarding the use of reserve antibiotics. So under reserve this thing best practice that I would like to share from my state is with regard to the establishment of the antibiotic smart hospitals in the primary care, secondary and tertiary care by government order. So initially the GO government order was for the 10 criteria to be satisfied by a primary care institution to become antibiotic smart. Of the 10 criteria, so one criteria is that the IPC part, you should have some sort of an accreditation like NQAS, or you should have a plan to have NQAS accreditation within next 1 year. But the most difficult criteria is that 95% of the antibiotics used in the OPD in that hospital should be from the access category. So initially we thought that, this is not possible, but, WHO initially said that 60% of antibiotic in a country, in a state or an institution should be from access. Now following the UNGA on September 26, now they have moved the goalpost to 70%, which I believe is a bit unrealistic. But still, we will stick with 60%. If you want to say ensure that 60% of antibiotic utilization is from access category, in our OPD, the antibiotic utilization from access should be more than 95%. And if you are going by WHO guidelines for any infectious syndromes, for almost all the infectious syndromes in the OPD, the antibiotic of choice is from the access category. It's either no antibiotics or amoxicillin, like that. So we set this target of 95% for the primary care. And 1 year back, 2 hospitals did achieve that. Then we realized that it is possible. Then the interesting aspect was they started demanding nitrofurantoin. All the primary care hospitals started demanding nitrofurantoin because nitrofurantoin was not there as a part of the supply from the government. Because if they want to treat cystitis, so the access antibiotic is nitrofurantoin. By any guideline, it was not being supplied. So they started demanding nitrofurantoin. And then the interesting thing is, after 3 or 4 months, they said that, azithromycin and cefixime should be removed from our hospital. So because azithromycin and cefixime are watch category antibiotics. So if it is there in the pharmacy, then, at the year end, they will be forced to give it to the patient. So they said that, from the government level, you should ensure that, nitrofurantoin should be supplied to the hospital and ensure that azithromycin and cefixime should not be supplied. So then the government took a decision that is from 2026 onwards, in the PSCs, 95% of the supply will be from the access category antibiotics. 5% will be from the watch because we have an issue with Shigella dysentery in the state where, our drug of choice as of now is cefixime. Okay, so 5% access watch antibiotic and 95% of the supply to the primary care center, it will be ensured that only access antibiotics are supplied. In another way, this is actually formulary restriction at the state level. So madam asked about formulary restriction or pre-authorization at the institution level, but this is an example of formulary restriction at the state level. But suppose the state had said like this, that you should be using only, we will be giving only 95% antibiotic will be from access. There would have been a huge protest against the state. But since the demand came from the ground level, it is easier for us. Because the doctors at the ground level demanded that you should supply only access antibiotics to us. So before starting or enforcing any policy, the most important step is teaching everyone about the practice of antimicrobial stewardship, teaching everyone about the threat posed by AMR to us. Then once, critical number of doctors and healthcare workers in the state are trained. So critical number is very, very important so that, they will actually, always there will be people who will speak against this. But we have to minimize those numbers. So the critical threshold has to cross. I believe that is around 70 to 75% of the healthcare workers. They're trained in antimicrobial stewardship, IPC and diagnostic stewardship. They will demand that you supply only these antibiotics to the primary care. So that is what happened in our state. And from 2026, only access antibiotics, 95% will be supplied. So that is the best practice I would like to share from my state.
Thank you. Thank you, Dr. Arvind. Certainly, I think what you've said is that formulary restriction requires a lot of education and awareness, and it should be acceptable to all. Otherwise, it is very difficult to do. So going on to the next question, which is to Dr. Ranganathan. So how can the clinicians adopt and sustain the behavior of self-directed reassessment while prescribing antibiotics?
Well, self-directed reassessment by a clinician is initially a tall order. So I would just go back to my original questions and answers. The first question which you asked me was, what are the factors that give rise to abuse and misuse of antibiotics in the private sector? That was the first question that you asked me. One of the things which we come across is, you tell me that this antibiotic is to be used. I'll give you an example. We had an outbreak of enteric fever this year in June, July, and that's a time when we have rains in Hyderabad with the southwest monsoon coming in Maharashtra. And along with that, we had Salmonella typhi. And we all know that our enteric fever, Salmonella typhi, is almost 85-90% of them are resistant to the quinolone. So quinolone monotherapy anyway is useless. And in children less than 6 or 7 years, we really do not encourage the use of quinolones because it is not so great. So then we said, okay, fine, you could probably, patients who are treated on an outpatient basis, probably one could use azithromycin along with cefixime. But then patients who are admitted to the hospital, we have to give ceftriaxone because they are in a very bad shape. And half of them come dehydrated and almost bordering onto sepsis with oliguria and so on. So the common dictum is, yes, the patient is admitted, please start ceftriaxone and also give oral azithromycin. Now, after about 48 hours, there was one case where I stumbled upon this fact that the clinician has already started off meropenem. I just phoned the pediatrician. I said, what leads you to give meropenem to a patient with enteric fever? I phoned you, I told you, we've talked about this. Yes, I know, you told me earlier, but then the meropenem, the ceftriaxone that the hospital gives me doesn't work. So what am I supposed to do for my patient? I can't let my child die. I said, nobody is asking you to let your patient child die. But then we could always talk about it. And then we stumbled upon the fact that the ceftriaxone brand was so poor. The potency of the antibiotic in many of these cases is very low. And when the potency is in question, you're just sort of giving powders, that's all. You're just reconstituting a vial of ceftriaxone, thinking that it is ceftriaxone with a 90 to 95% potency, but then it really doesn't even cross 50 to 60%. And in such cases, that ceftriaxone is not going to work, particularly when the bacterial load is very high. So in such cases, there is a temptation for clinicians to go on to a higher antibiotic like piptazo or meropenem, even worse. So one of the things is help them reassess. And probably we keep phoning them. Now what we've started doing is, yes, on day one, we say it's a gram negative. Then we put up a rapid antimicrobial susceptibility. We say, no, this looks like a salmonella because quinolones are resistant. And then we do a serotyping and we tell them, yes, this is Salmonella typhi. Please go ahead and start off ceftriaxone plus azithromycin. After about 24 hours, when the final reports and everything is out, we ask them, how is your child doing now? And then the answer is, okay, marginally fine. The fever spikes have come down, but then they're still there. No problem, just continue it and we'll talk after another 48 hours. Another 48 hours later, again, I make it a point to phone back and say, now how is your child? By the time the child should be out and discharged or going to be discharged the next day or something of that sort. If not, then we say, the next thing is there is a problem with the ceftriaxone potency, and this has happened about 2 to 3 times. And I insist saying that no, just ask your child's parents to go out and get Monocef. If it is not available in the hospital formulary, please insist on Monocef, which is the original ceftriaxone molecule, and give it. And lo and behold, sure enough, in another 48 hours, when that is given, they say, yes, now it's worked. And it's working wonders. And you know for sure why it's working wonders. That is because the earlier used ceftriaxone had no potency. The second thing is we try and have weekly meetings with all our, there is a neonatology round, there is a AMS pediatric ICU round, there is a hemato-onco round and so on. And then when we keep asking, what are the fresh cases that have got admitted? What did we discuss last week? What did we discuss day before yesterday? That is one way by which they say, oh yeah, you told us this, na? So I think we should de-escalate now. Fine. Just go ahead and bring down this antibiotic to this. That is one way by which probably we could induce clinicians to reassess themselves and bring down their antibiotic usage. But then, as I said earlier, neonatologists and pediatricians and obs-gynac people generally listen. It becomes slightly more difficult when you have adult physicians, pulmonologists, and chest medicine physicians, and of course, cardiothoracic surgeons and neurosurgeons are quite difficult to tackle many a times. If they are not friendly with you, it makes it even more difficult.
Yeah. Thank you. Thank you, Dr. Ranganathan, for sharing some solutions and the challenges that are there in the reassessment by clinicians. So I would ask the next question, which is the last question on this panel discussion, and then we will take up questions from the audience which have been received. So I would like to ask Dr. Arvind. Dr. Arvind, in India, with easy over-the-counter availability of antimicrobials, use of antibiotics in human health continues to be the predominant contributor of AMR. The Schedule H prevents sales of antibiotics without a valid prescription, but antibiotics continue to be sold without prescriptions. Would you like to share any best practices from your state on this issue?
Very true, madam. So even though we say it is a One Health problem, we know it's a One Health problem, but still, there is a lot for us to do because, if you're looking at the stratified antibiograms, because, our state has district level antibiograms as well. We have data from the taluk hospitals which show that we don't have any carbapenem resistance there. And the ESBL rate compared to the state average is actually only 50% in the taluk hospital, secondary tab. So we have this Habansburg model, etc. So what madam said is it's true, very, very, very much true. That is, there is a lot that we have to do. So when we talk about that, one of the most important things which can be implemented is banning the OTC sale of antibiotics. And actually, India did do that in 2011. But the issue was then the access issues are there. Certain states, they don't have access to doctors and all. And there is a Lancet study saying that the leading cause of under 5 mortality in some certain pockets in India was lack of antibiotics rather than antimicrobial resistance like that. But our state does not have that much of a problem because we have a surplus of doctors and our PHCs are very good. So after 5 years of launch of our state action plan, that is CARSAP, in 2022 December, a minister said that if antibiotics are dispensed without prescription, the license will be cancelled. That was in 2022 December. So that was said then, but then did not lead to much change in the practice. The OTC actually went on without, even though that means that was declared by the minister, it did not lead to any drastic reduction in the antibiotic sale, etc. But in January 1, 2024, Operation Amrit was launched. Amrit is actually antimicrobial resistance interventions for total health. It was launched by the Drugs Control Department under the Health Department. So along with the statement that, if antibiotics are, dispensed without a prescription, the license will be cancelled. This time, a magic number, it's a toll-free number was given. It's 1-800-4253-182. This is a magic number. So in December 2023, just that announcement was made, but there was no change in the prescription practice. But in January 1, 2024, the Amrit program was launched and toll-free number was given to the public. That means that if you are going to a pharmacy and you are getting an antibiotic without prescription, as an antibiotic literate citizen of Kerala, you can use this number to formally lodge a complaint, and the Drugs Control Department will look into it, and the license will be cancelled. But before launching this, very, very harsh legislation, we have been educating the public about the problem of AMR, the problem of OTC sales of antibiotic right from 2019 onwards as part of the antibiotic literate Kerala campaign. And the concept of antibiotic literate Kerala campaign is actually people-centered approach to AMR or the participatory stewardship, where it is the responsibility of each and every citizen of Kerala to ensure that the AMR is tackled. So there was a huge acceptance from the public, I understand. And since this toll-free number is also there, now the data shows that, so 9 months after implementation of this, there is a 20 to 30% sale in the antibiotic to the tune of around 1,000 crore like that. There's a OTC sale from the pharmacists alone. It's not the hospital sale. So that means that, just by education alone, we may not not be able to bring down OTC sales. Education has to be backed by some sort of a stringent legislation and a tokens like a toll-free number. And then certain people have told that, I have gone to a pharmacy and then I got antibiotic without prescription. Then we used to ask them, as an antibiotic literate citizen of Kerala, why didn't you make use of that toll-free number? And you should not make complaints against us. We gave the toll-free number so that you can as a responsible citizen, you should have made use of that number, etc. That means that we have made everyone in Kerala a part of this AMR control activities. So that is the importance of that toll-free number, madam. Okay.
Thank you, Dr. Arvind.
I'd like to just weigh in over here. Very interesting thing that Dr. Arvind said. Same thing happened during the COVID time also. That the moment you try to get a paracetamol from a chemist, immediately a call came on your phone. Used to come on your phone that they are going to come to your home for screening for COVID. So the dispensing of the drug itself is a marker that this antibiotic has been prescribed or something like this. So that can be monitored digitally.
Yeah. So I think what Dr. Arvind has said, that what we need is a combination both of awareness, education, and also some kind of stringent regulations. Both are required. So now I go on to the questions that we have received from our participants who are attending this webinar or panel discussion. So the first question is, I would like to ask Dr. Sumit. So Dr. Sumit, there is a question which says that, can laboratory practice cascade reporting of antimicrobial sensitivity results to control, antibiotic use?
Yes, we are doing cascade reporting, and the best part is that in the HUNET only there's an option of doing the cascading. So whenever we are doing the reporting, we are taking the tier 1, tier 2, tier 3, tier 4 list of antimicrobials as per the CLSI next to us, and then when we are putting the report, so that we see with an enterobacterial list, then we put up the tier 1, tier 2, tier accordingly. So we are not really following that aware classification, but we are following the tier 1 that classification we are following. So we can cascade it then and there itself. So the report, all the antibiotics, they get entered the HUNET, but only the ones that you want to display to the clinician, only they get printed on the PDF. So we take the PDF and the customized report and then send it to the clinician. So we can do cascade reporting.
Yeah. Okay. So that's a good. That's something that even the labs who may not have full-fledged antimicrobial stewardship can initiate as a first step. It's a low-hanging.
HUNET is very comfortable that way. HUNET.
Yeah. So one more question that has been asked is that, is there any role of a stratified antibiogram in tertiary hospitals to reduce inappropriate use of antibiotics? Like, go specimen wise or, unit wise or ward wise or ICU wise.
Yeah, so we can make stratified antibiograms. Like I said, we can make the consultant specific antibiograms also. We can make unit specific antibiograms depending on what is the information that is being given to us on the test requisition form. So that TRF is the most critical part that gives you, because we don't have the patient immediately with us right now. We do have the TRF that will give us all this information. So if you want stratified antibiograms, we need the information on the TRF. So on the basis of that, we can make it specifically. If you want for the diabetic foot infections, we can have a stratified antibiogram. If you want specifically for skin and soft tissue infections, so we can have syndromic and site-specific antibiograms can also be made if the information is given us completely on the test requisition form, because everything HUNET will accept. The fact is that you have to give us the proper information.
Yeah, thank you. So next question is to Dr. Ranganathan. Dr. Ranganathan,
Yes.
I want to ask you this question posted by one of the participants, one of the attendees, and they have asked, what is the role of biomarkers, procalcitonin, CRP, interleukin 8 in reducing antibiotic duration?
Well, I think most of these biomarkers are all acute inflammatory markers. And CRP tops the list among the most non-specific markers, followed by PCT and the others. Probably they can be used more appropriately to stop antibiotics which are there rather than to start antibiotics. I think beginning antibiotics cannot be based on biomarkers. It's got to be based on clinical presentation, the clinical condition of a patient, how emergent the situation is, and what are the organ systems, and what is the kind of what's the working diagnosis or differential diagnosis that a clinical department can zero down on? That's what will mark the institution of antibiotics. Stopping antibiotics can come later on with biomarkers.
Yeah, thank you. I think as we used to learn, treat the patient, not the test, so that
Exactly.
is very, very
Yes,
applicable
yes.
for biomarkers. Yeah. So next question is to Dr. Arvind. So Dr. Arvind, there is a question which says that, how do you address the challenge of stopping antibiotics when patients improve clinically, but blood cultures remain positive?
Yes, that's actually a bit tricky question. Depends on what is positive in the blood culture, and we need to say whether the blood culture was collected in the right fashion. That is why we always insist on paired blood samples on two sides. For example, one side is growing Acinetobacter and patient is doing well. I will stop the antibiotic. It would have been a skin colonizer. But suppose it is an MRSA or a MSSA or say a Candida or Pseudomonas, etc., and then I will be a bit wary about these sort of things. And for staph aureus, we have evidence showing that if after 4 days of correct antibiotic, if the blood culture is remaining positive, we actually should look for the site of infection. Like means anyway we will be doing an echo, but if echo is normal, then probably there could be an osteomyelitis. In 20% cases, it will be asymptomatic osteomyelitis like that. So if after 4 days in staph aureus is remaining positive in blood culture, probably you need to look for metastatic sites, because then the duration is not going to be say 7 to 14 days. It's going to be say 4 weeks and on. But 2 days back, the balance trial was published. That is in gram-negative bacteremia, comparing 7 versus 14 days. 7 days was as good as 14 days. So to this question, I will just like what Madam said, look at the clinical situation, hemodynamic situation, what organism actually grew from the culture. So it is like say corns or say Acinetobacter from one site and all. Probably I may not give that much importance to the blood culture.
Yeah. Okay, so one more question to you, Dr. Arvind, which is, multiple stakeholders are involved in an antimicrobial stewardship program, and how can accountability be ensured of the AMS action activities?
Actually, this regarding, so Smith sir said that IPC committee and antimicrobial stewardship committee actually they meet separately. In our institution, the only person who is different from both this thing is actually the pharmacology HOD. So the rest of the people are the same. That is, the microbiology, ID, then HODs of all the clinical departments, the infection control people, and anyway, the superintendent is going to head the committee. So that is the infection control committee, and antimicrobial stewardship committee. Along with that, the clinical pharmacology HOD is also actually coming into the picture. So everyone should have their own roles and responsibilities, designated. That is why we insist that as part of the antibiotic smart hospital, we need to have a written down IPC plan for the hospital. We need to have a written down antibiotic stewardship plan for the hospital, and we need to have a written down diagnostic stewardship. It is not that when we are going for inspection, we are having this committee. That does not make any sense. We ask for the minutes every month. The minutes of the IPC committee should be there, antimicrobial stewardship committee there. We ask for the customized the plan like this sort of thing. Despite doing all these things, your resistance might be high, but that we can't help. What we can look at is that we need to get all the processes right. Outcome probably is not in our hands, and probably outcome might take for years to manifest. But the processes has to be in this thing. Rather than looking at accountability, it is a teamwork, and we don't want to blame someone for the faults, etc. So basically, it has to be a teamwork, and we don't anyway the roles are there, but it has to be a teamwork.
Yeah. So it has to be a teamwork, and it's not a question of accountability. It's more of a question of passion and working together and, like really having the passion to make things happen. So the next question is about antibiotic cycling. I don't know who would like to take that question. Is antibiotic cycling an effective way to combat AMR?
Actually, antibiotic cycling is of two types. There's a homogeneous cycling and there's a heterogeneous cycling. So what people tend to do is that they will stop one antibiotic and then they'll, for some time, for a few years, then they'll start another antibiotic. So with multiple studies, it's been found that it doesn't really help. So there's a heterogeneous method of antibiotic cycling where you keep the antibiotic same, but you keep on circulating in different wards. So you don't restrict it to one certain area and then another antibiotic you circulate in different wards. So that cycling is varying between two different wards and units. So that seems to be works better as compared to a restricting totally restricting one antibiotic and then starting another one. So the heterogeneous type of antibiotic cycling works slightly better as compared to the homogeneous antibiotic cycling.
Yeah. So another question to you, Dr. Sumit, is that if a lab has not so many number of samples, and it's doesn't have the statistically correct number of samples and is not able to develop an antibiogram, so what should the lab do? How, and is it necessary for an antibiogram to be developed to guide empirical therapy in an institution?
Yeah, so this is a very typical issue that happens with the samples with the lab with the low number of samples or low number loads, or many times even with the your standalone labs also. So many people, the standalone labs also say that the clinician is asking for data. So what do we do? So those labs, like the labs with low number of samples, they can always team up with few labs in the neighboring district or the areas, combine their samples together, combine their isolates together, and form a combined antibiogram. Like sir was saying, there's a district antibiogram that can be made, something like that. Other option is that you can always combine the number of the isolates. For example, you may have Citrobacter frundi, you may have Citrobacter kozeri. So you can combine the species into one genus also. Or if you don't have that, you can combine Klebsiella oxytoca, Klebsiella aerogenes, and Klebsiella pneumoniae together as a single Klebsiella species. So those are the possibilities. And if that is also not possible, then you need at least 30 number of isolates. So I think with the entire year, 30 isolates would be possible in the entire year. So that 30 is the magical statistically significant number that we are able to put in our antibiogram. So I think 30 isolates can be manageable. If not, then you can combine the species into one common genus, and that is not possible. Then you can team up with a lab which is in your district or in your area, maybe a few kilometers away, and you can combine your isolates and form a common antibiogram.
Okay, so another question to Dr. Aravind, that is there any role of artificial intelligence in antimicrobial stewardship?
Definitely, when our intelligence is not working, we can look at artificial intelligence. But actually, we need to get a lot of fundamentals right. Before getting AI into the picture, we need to get, the fundamental means, prevention of infection is hand hygiene. For monitoring the hand hygiene compliance, we have AI tools. Okay, for that, we can use that. For monitoring purpose, AI tools can be used. But means, I think one company in India has manufactured a tool which can monitor the 5 moments of hand hygiene like that. So for monitoring purpose and for generating these high surveillance rates and all those things, so high surveillance, etc. In majority of the Western countries, everything has been outsourced to the AI-based systems and all. For surveillance, it works well, and actually for educating the peers, we can use an AI-based apps are there. So we have the state has launched an AI-based app, antibiogram app, to engage with the students as well as the practitioners regarding how to help them in selecting the right antibiotic. But the thing is that the net connectivity is very essential. There's, in our hospital, net connectivity issues are there, but we came out with a beautiful app, but it did not work at the bedside. So we actually added more modules to it, and now we are using it in IEC resources. So AI definitely has a place in everything, but before thinking about AI, this thing AI-based interventions, think about the basics that we can get right, like prescribing the right antibiotic at the right time, right dose, right duration, and all those stuff, and also the 5 moments of hand hygiene.
Yeah, thank you. Thank you for that. Another question is, how can doctors restrict antibiotic use when patients demand antibiotics for a faster cure?
Actually, so this is why the education is very, very important. So because without educating the public, it becomes a problem, because when we actually sort of said that OTC should not be given in say 2 years back, then the majority of the media went and interviewed the pharmacist. It was just like portraying the pharmacist as the bad person. They said that we may give some antibiotics, but then doctors are also using antibiotics for flu and all. So you go and ask the doctors. Doctor said that it is the patient who is demanding. Then they went and asked the patient. They said that no, we may demand sometimes, but even without that, no, you say that 95% of rhinitis is due to virus, but my doctor gave me amoxicillin always, sometimes augmentin like that. So all the stakeholders have to be educated. So that is the concept of this antibiotic literacy. It's not. We started with antibiotic literacy. We started in 2019. Initially, we trained all the doctors. We have customized models for modules for doctors, then other healthcare workers. Then we actually targeted the pharmacists. For that, drugs control department is running a program. Then we actually went to college students, then the school students, and then at the last, this thing we targeted the public. So in order to engage with the public, an ID HOD talking to the public does not make sense. They will listen to their doctors, that is their doctors in the PHC. For that, actually, we started district level AMR committees, block level AMR committees, and antibiotic smart hospital initiative. I will say that around 2017-18 time when the CARSA was launched, maybe there would have been around 10 doctors who could engage with the public. Okay. Now, during this World Antimicrobial Awareness Week, in each panchayat, their doctors are taking class and they are actually going to Agashwani, Doordarshan, etc. So we have, say, more than 1,000 AMR champions. It takes time. But through that, we can engage with the community. And when the community is educated, then the demand on antibiotics also will come down.
Yeah.
Can I just add to this?
Yeah, please, Dr. Ranganathan.
Yeah, I think Dr. Arvind has brought out a beautiful point. And to summarize that entire thing in one sentence is doctors must be patient, and they must be patient enough to spend time to talk to parents, talk to their patients, and make things understand. Everything doesn't start with, people just keep looking at a particular patient who is walking in and you start writing a prescription even before that person has had time to sit down and explain what they are suffering from. So it's a malady, I would say, where a physician or a surgeon or somebody has to see something like 100 patients a day. And that is when no talk happens, no discussions happen, and people just pick up one prescription like a bit of paper and they go out, not knowing what exactly is hitting them or what they are in for. So everything depends upon how good conversation a physician has with his patient.
Yeah. Yeah, that's true. So communication has a very important role, agreed, and as highlighted by both our physicians and the microbiologists. So another question, again, to I think Dr. Arvind, is that any recommended resources to learn antimicrobial stewardship, and to start antimicrobial stewardship, who should be the team members for rolling out the program?
Actually, there are enough and more resources. WHO has a course, ICMR has a course, the Clinical Infectious Disease Society of India has a course. Our state, rolled out a 6-hour module for our physicians in 2021. So now we have enough and more resources. So that is not a problem. The will to study and will to be part of the team is the most important thing. The second aspect is, what Sumit sir did already mention. So based on our logistical availability, you can constitute the antimicrobial stewardship team. So ID is not mandatory because ID is we don't have enough ID in the country. But clinical microbiology is actually good enough. Suppose your microbiologist is not really a clinical microbiologist, still you can become a clinical microbiologist. The thing is, we have insisted that we should have antibiotic stewardship committees in all the hospitals in the state. So at the PHC level, they don't have a microbiologist and they don't have an ID person. So the doctor there is a AMR champion. Okay, so because the basic concepts of AMR can be practiced by anyone. So you need to take the responsibility. So there the stewardship team will be, the administrative officer will be the doctor per se. The pharmacist is there. So pharmacist, it's not a MD pharmacology and anything like that. The pharmacist will be D Pharm or B Pharm, something like that. So basically, based on the available resources, people who have the concept about AMR, the passion for AMR, based on them, you can constitute the antimicrobial stewardship committee. And based on your challenges, whatever you can do should be done. It's not that, you should practice all the core elements of CDC or anything like that. You customize that. Based on that, you customize and have your own stewardship mode applicable to your institution.
Yeah, thank you. So to Dr. Sumit, one question that even after a culture report, is, showing if some inappropriate, even after culture report is out and the inappropriate antibiotic use is continued, should the microbiologist suggest and sign the case sheet?
Yes, ma'am. So what we do in our setup is that we, for all the IPD cases, we are following up the prescription auditing. And to reiterate, these have been officially sent and circulated by DG sir himself about prescription auditing and pre-authorization, and bare below the elbow policies all have been endorsed by DHS office or DHS also. So considering that, we do our prescription audit round, and then whenever we find anything odd or out of the blue as per the AST report, which is not in sync with the AST report, in that case, we inform the clinician personally and on the phone. We at the moment have not been authorized, or rather, I would say we have not minutized whether we should be writing on the case record sheets or not. What we have now done is that instead of writing on the case record sheets, at the best we do is we put up a sticky note over there that this has been seen by the AMS team, and this is what is going on. This is an outlier, and this is what we suggest. So accordingly, they will make the changes, and the next day we follow it up. So most cases they will change it, but at times they won't, because many times either the note is lost or they have not seen the note at all. So that one point of contact in the different ward, once we identify that one single point of what we call as the AMS, the contact AMS person in that ward is identified, so we can make that person accountable. So we are in the process of doing that right now. Because yes, we put up a sticky note on the case files. Right now, the clinicians have put some kind of resistance that microbiology should not write anything on the case record, because that becomes official then.
That's true. So I think we have just one or two questions which we will take up because we are coming to the close of this webinar. So Dr. Aravind, how do you implement stewardship in peripheral and primary healthcare settings?
Actually, that is why, we came out with the antibiotic smart hospital initiative for the primary care. This is antibiotic smart hospital means they have to satisfy 10 criteria. So when we are looking at the national action plan or the state level action plans, there are 6 strategic priorities. So first one is IEC, that is creating awareness. Second one is surveillance, that is, antibiograms and all. The third one is IPC. Fourth is actually antimicrobial stewardship. Fifth is research, and sixth is collaboration. So basically, at a primary care, you need to look at the 4 targets. So the 10 criteria that they have to meet includes the components from the 4 targets. For example, IPC means they should have some sort of an accreditation like NQuest, or they should have a plan to become accredited in the next 1 year. IEC means, they should have posters in your languages. Our language is Malayalam. So we will have Tamil neighboring, neighboring areas of Tamil Nadu will use IEC in Tamil. So in Kasaragod, we will use Kannada, messages in Kannada, because some of them speak Kannada like that. So IEC messages in Malayalam. Second is aware categorization of antibiotics. So posters of aware in front of each prescribing area, in front of the doctor, like that. Then you should have an infection control committee. You should have an antibiotic stewardship committee. Both should be functional, that every month you have to meet, just not in the name. So based on the available members in the PSC, okay, it's not that a clinical microbiologist ID are not mandatory. So whoever is available, they will form the committee. The next will be fortnightly IEC for the public, and that is usually given by the pharmacist, because in a single person doctor clinic, the doctor may not be able to give that much time for IEC. So we are making use of ASHA workers, JPHN, pharmacists, everyone is trained, so they can train the public. That is how we have launched this house-to-house campaign, where it is not only in Ernakulam, it is in all the districts of Kerala. The ASHA is going to the households and they are doing this campaign with printed messages in Malayalam, because AMR is very, very tricky. So we cannot just ask the ASHA to explain what AMR is. So they go with this customized messages in Malayalam, and they are supposed to speak only those messages. So the state has come out with an IEC this thing. There is a dossier. So only those messages should be used for communication. And then something which I already mentioned, 95% prescription should be from the access category and all those things. So based on these 10 criteria, the hospitals can actually improve the access. Basically, it is a quality improvement initiative. So like that, this is the primary care stewardship initiative, which takes care of all the 3 aspects, all the 4 aspects of stewardship. And then secondary care, the criteria is different. So we have customized model for each tier of healthcare.
Yeah, so thank you. And one last question to Dr. Ranganathan. Dr. Ranganathan, who should be the, in the antimicrobial stewardship committee to begin with, who should be the members?
Well, it's much better to form a smaller team and then increase the committee. So it would be much better to have the medical director or the medical superintendent to start with, the clinical microbiologist. If there is an ID physician, then that would be an added bonus. Definitely the pharmacist and the infection control nurse. And her team of link nurses. This is something which would be a very good start point, and then you can add everybody else, the surgeon, the pediatrician, and everybody. But then this is the basic minimum.
Thank you. So I always remember this point about in the West, the infection control nurses are highly empowered both for infection prevention
Yes.
and antimicrobial stewardship. So we could, though we have a lot of dearth of nurses, but already we are struggling in that area. But thank you for that answer. And I think there was one question which I would just like to answer myself is if somebody is talking about ceftriaxone-resistant Salmonella typhi. So I just want to share that at the national level, we do surveillance of Salmonella typhi AMR, and we have seen that there are only some pockets where there are outbreaks which are happening, but overall at the national level, our resistance to ceftriaxone continues to be less than 0.1%. And so it's just some pockets which are, and the other part of that question is what do you do if Vidal is the only test and blood culture is not accessible? So we agree blood culture must be accessible and we must have good labs, and I think at the national level also, we are trying our best to have access to labs. And Vidal is certainly not a test, which you can rely on much, especially in the first week when the cultures are positive and the treatment needs to be started. So, so I think with that, any last remarks by our panelists? Any one comment that you would like to make before I close? Yes. Starting with Dr. Sumit, Dr. Aravind, and Dr. Ranganathan.
Well, I would definitely say start antimicrobial stewardship at the community level. We do have all wonderful committees for functioning quite well in the large tertiary care hospitals. But then AMS in the community is a huge challenge, and that must be addressed very emergently.
Yes, absolutely. Because like I reiterated also, the community stewardship is one thing that's still untapped, and Kerala has done it wonderfully. AIIMS Bhopal and AIIMS Vijayanagar are also trying it. So we need to take it to the community. And again, the Department of CFM and PSM can be tapped. That's one department that's actually in contact with the community on a daily basis. So we can start with the PHCs also about this, and the systematized literature can be made that can be understandable for the local community also in the local language. That's most important. And the best part is that the workers have to be they can relate with the local people. Unless until they don't relate, so they will not understand what are the seriousness of this matter.
Yeah, Dr. Aravind, your last comments.
I would like to say that, we should not wait for everything to fall in place to start this stewardship or IPC activities. So the time to act is actually now, because AMR is not tomorrow's problem. It is today's problem. I would like to end by quoting Martin Luther King. So if you can't run, you have to walk. If you can't walk, you have to crawl. But keep moving forwards for AMR and our sake as well as our future's sake. Thank you very much for the opportunity.
Thank you. Thank you so much. So the two key points which I take back from this panel discussion is 24/7 labs are essential, and making microbiology a clinical subject, and also the passion to move to establish antimicrobial stewardship committees and the team members is very essential. So just to close, I would like to convey our heartfelt gratitude to our DGHS, Director General Health Services, Dr. Atul Goyal, for his support and participation for today's panel discussion on this most important topic despite his very busy schedule. I thank all our panelists for the active participation in today's panel discussion. And finally, I take this opportunity to thank all our 500 plus 565, I think, or 70 viewers, and for submitting their questions, which made today's webinar highly enriching. And we hope today's discussion has empowered you all to initiate at least some antimicrobial stewardship practices in your healthcare facilities, clinics, or individual clinics. So that's it. And thank you so much, everyone. Thank you, everyone. Thank you, the panelists.
Thank you, ma'am.
Thank you,
Thank you,
Japaigo. I want to
sir.
thank Japaigo for supporting this initiative. Thank you so much.